so grateful for. So let's get those questions rolling. If we have time, and only if we have time, we could maybe, we've had quite a few helpline calls, people during COVID trying to look after themselves, Vinod, and one or two people, they found out they've overdosed on vitamin D, vitamin C, vitamin B. So only if we have time, feeling which we'll hand it to one of the older doctors. Okay, welcome everybody, and let's get this going. Hello everybody, we've got Margaret, Jean and Melissa. Hello to everybody and welcome.
Okay, perfect. Thank you. Right. Good afternoon. Good morning. Welcome. So we are trying something on Facebook. So we are live. Right. Okay. A nice, easy one for you to start, Vinod.
Well,
I'm going to give you some background information, much of which you will know, but I'm going to just summarize for everyone who's listening and watching today before I ask you the question. So we know that alk phos in a normally high number is associated with PBC.
Yeah.
We know the ursa response is measured principally in terms of trying to normalize the alk phos number.
Yeah.
We know that in PBC terms, alk phos or ALP or alkaline phosphatase, we know that that refers to cholestasis, and we describe PBC as a cholestatic disease. So the easy question is, what does cholestasis actually mean? And then the really, really easy question is, how does ursa work?
Right. Okay. I'll tackle the easier one first. The literal meaning of cholestasis, you can break the word into two parts, chole and stasis. Chole basically means bile. Okay. Stasis means stagnation or impaired flow. So cholestasis means basically stagnation or impaired flow of bile. And that is a generic word given for any condition that causes impairment of bile flow. Bile is produced in the liver. It trickles down through the bile ducts into the gallbladder. It gets stored there and it's released from the gallbladder into the bile duct. From there, it comes into the small bowel. And bile is very important for digestion of fat and other important functions. So cholestasis essentially means stagnation or impaired flow of bile. PBC is not the only condition that causes it. There are a number of other conditions like as primary sclerosing cholangitis, drug-induced liver damage, etc., etc. If you have got a bile duct stone, which is blocking the bile duct, it also causes cholestasis. But for this afternoon's meeting, we are just obviously focusing on PBC. Hope that answers. The second question, how does ursa work? It's $1 million question. There are a number of hypotheses how it works. I always tell my patients in a simple word, basically ursa detoxifies your toxic bile. In PBC, because there is impairment of flow to the bile, lots of toxic bile acids are building up in your liver cells, and that is what causes the damage to the liver cells. And ursodeoxycholic acid has got beneficial properties, and it enriches your bile. It reduces the toxicity caused by the bile acids, so therefore it reduces the damage to the liver cells. So it's an antioxidant, it's anti-apoptic, which basically means it reduces the death of the cells, and it's a bile acid detoxifying agent. So those are the three reasons how it works. Some people say it is anti-fibrotic as well, which means it reduces the fibrosis or scarring in the liver, but that's not entirely proven. So for simple layman or a patient's point of view, it is enough to understand that ursa is a detoxifying agent, and it, as I said, it reduces the damage caused by the toxic bile acids. Is that enough?
Okay. Perfect. That's really, really helpful. So
a miracle. It's a miracle, isn't it?
It is.
So there you go. So I always wondered how cholestasis was the stopping of the bile flow, but now I think of it as stagnation. That's really helpful.
Yeah.
So thank you for that.
I knew that.
There we go. So,
I don't
um,
think there's anything Collette doesn't know. I don't
yeah.
think there's
So, um,
That's because I'm old, Vinod. That's all it is. It's age.
so if I can follow up with just again in my head, what feels like a simple question, but that doesn't make it an easy one. The attack is on the bile duct cells themselves, the cholangiocytes, the
Yeah.
biliary epithelial cells, if you want as well. So, is there an impact that urso has on that attack, or is it the fact that the urso is solving the bile stagnation, which then allows the body to repel the bile cell attack? Does that make sense?
Yeah, I guess I can. I guess. Well, urso does not increase the flow of the bile.
Okay.
I don't think it does. It's not a. It's a choleretic agent, which basically means it is supposed to improve the flow of the bile, but there are far better drugs yet to come to improve the flow of the bile. Urso does it, but not as much as I would like it to do.
Okay.
So whether does it directly help the cholangiocytes, I don't think there is any evidence to prove that as a basic science. In my mind, as I said earlier, urso essentially works by changing the composition of the toxic bile acid milieu in the liver.
Mhm.
And by changing that composition of the bile from toxic to less toxic, it helps in that way. Um, so that is the nature of its action. And what was the other question in built in that? Um,
So
was it?
it was more to do with the fact. So obviously, as people respond to urso,
Yeah,
disease progression slows down,
yeah,
and therefore the attack on the bile duct cells themselves
yeah.
isn't as consequential.
Correct,
So
correct.
I guess my question is that a happy coincidence from urso doing its thing,
Yeah.
or is urso doing something to protect the bile duct cells?
Well, I would. The main action is to improve the bile flow, reduce the toxicity, and improve the alkaline phosphatase. The reason your alkaline phosphatase is coming down is because there's a better flow of the bile along the canaliculi of the cholangiocytes. Along the canaliculi, the flow is better, therefore the alkaline phosphatase goes down. And by doing that, it is helping the hepatocytes or the liver cells and reduces the damage to the hepatocytes. There is less scarring, less inflammation, so therefore less scarring, and therefore less chances of getting cirrhosis. But as I said, I would like to see in the years to come a better agent which does a far more superior job than urso in terms of improving that flow. Get rid of that stasis, get rid of that stagnation, and improve the flow of bile much better than urso does.
Yeah.
It is a wonderful drug, as Collette said, but it's not 100%
No,
perfect.
it's not. It's not the answer yet.
Not yet.
So, okay, perfect. That's really, really helpful. And I love the fact you put that into lay terms. So we've got another couple of questions which are asking specifically to put things that we often talk about into lay terms. But if I can stay on urso first, is there any advantage in taking urso in two doses versus one dose, or three doses versus one dose a day? And are there any interactions or contraindications with other substances or meds that comes with taking urso?
Two excellent questions, which always comes up in clinic consultation. In terms of whether you take it once a day or split the dose into twice or three times a day, it actually doesn't matter. I encourage patients to take it in one go if they can tolerate, mainly because it's easier and the compliance is better. Imagine if you have to take a tablet for rest of your life, and if you have to take it three times a day, every day for rest of your life, you're likely to forget 1 or 2 days. You're likely to take it as a burden. You're likely to be less compliant. If you have to take a tablet or 2 or 3 tablets together once a day, for me at least, that's far, far better. I encourage patients to take it in the evening, okay? Especially we all have busy days and we come home in the evening, relax, have your evening meal or something, then you take your ursa. You make that as a routine, it becomes less cumbersome, less burdensome. So if you can tolerate, say, 3 capsules or 4 capsules of urso taken all together in one go in the evening, please do that. But some people, if they take so much of urso, they get abdominal bloating, they get pain in the tummy, they get diarrhea. So they don't like it. For those patients, I would say split the dose. Either you take 2 capsules in the morning, 2 in the evening, or 1 in the morning, 3 in the evening, something like that. So listen to your body, listen to what it is saying to you, and adapt accordingly. What is important is to take it, okay, every day. And whether you split it or take it in one go, it doesn't really matter. But for purely for compliance sake, please take it, if you can, all in one go.
Yeah, it's worth noting as well that we do get brain fog, and you do think to yourself, did I take that? I know I meant to. And with the best will in the world, so if you can in a 1 hour, it's a great idea.
Yeah.
And I know many people that works for them. Yeah.
Regarding the interactions, the only interaction I would be wary of is if you're taking anything for itch. For example, if you're taking cholestyramine, or it's also called Questron or Cholestagel, those sachets that you are taking for itch, that is the only agent which I will be careful, because it impairs the absorption of urso. So don't take Questron and urso together. So space it out by at least 2 to 4 hours, I would say. And that's another reason why I prefer patients to take urso in the evening, because if you're taking Questron, which is for itch, it's usually given in the morning, and that works better in the morning for scientific reasons. So take Questron in the morning, take urso in the evening. I don't think there's any other interaction with any other medications.
But it's also worth saying as well that many people with PBC take blood pressure tablets or tablets for other things. But your chemist, your local chemist, those people behind the counter, they have a wealth of knowledge about what medication interacts with whatever medication. So never hesitate. They're always very keen to chat with anybody to help them through. And if you've got a list of maybe 5 or 6 things, which some people do, don't hesitate to check with them as well. They are very clever people.
Yeah, absolutely.
Robert, that's £10. He forgot to put his microphone on.
16 months I've been doing this. 16 months, and I
never got a penny out of him. We never got a penny.
Always want to learn a lesson. Right, next question for you, Vinod. So while we're on the subject of urso again, one more that's come up. How long do we wait to find out if urso is working, and why?
Right. Again, a very good question. The current thinking is you should wait for 12 months. You start the urso following your diagnosis, and you take the blood tests before starting urso, and you do a blood test at 12 months. And the assessment of response or non-response is generally done at 12 months. And that is the current thinking. There's also some thought about doing it sooner. You can do urso response assessment at 6 months, because you can identify those high-risk patients early on and prepare them for second-line therapy.
Yeah.
Have I done that in my practice? I've started to. By 6 months, if you're taking urso, tolerating it very well, and if your alkaline phosphatase is not moving, I'm thinking that you're unlikely to respond by another 6 months. So I'm already worrying about the patient. So yeah, you can check at 6 months, but most clinicians would check at 12 months.
Within a year. Good.
Okay,
within a year.
perfect. That's helpful. Thank you. Okay, so we've got somebody here. Now, again, we don't give medical advice. We do give medical information. And oftentimes the information we give is, where do you go next? What's the next question? So we've got somebody here in the Click meeting room who's saying they had a Fibro Scan of 19,
Okay.
a really high alk phos. If this is your question, feel free to pop in the comments how high your alk phos is. Not really had any communication from their gastro. So their question is, that's fairly high. What do they do? What questions should they be asking? What can they do to empower themselves in their own self-care?
If I may just say, I think I know who this person is who came yesterday onto my 4 o'clock, who I think is newly diagnosed with PBC.
Right. Okay.
Is you right, Sarah? Great. That's fantastic, because that's important for Vinod to know before he answers your question. Thank you, Sarah. Yeah. Great.
Did you say you've got the reading? What's alk phos?
748.
748. So she's newly diagnosed, Vinod.
Yeah. It's worrying, isn't it? I'm sorry. It is worrying that your Fibro Scan reading is high at 19 and alk phos is 700. But if you are newly diagnosed, there is no reason to lose hope, because your treatment will be exactly like any other patient, at least in the first 6 to 12 months. You need to start ursodeoxycholic acid ASAP, based on your body weight. There is still a good chance that ursodeoxycholic acid will significantly improve your alkaline phosphatase in the next 6 to 12 months. And that alk phos may come down from 700 to 200. Okay, I have seen that happening. Fibro Scan reading, we need to be a little bit careful at baseline, because we know that such a high level of cholestasis does give you falsely high readings. So don't get disheartened by such a high reading of Fibro Scan, okay? Because we will repeat that in 12 months. And I won't be surprised if the Fibro Scan reading comes down in 12 months, because again, that's an urso effect. So I would say just take the medication, ursodeoxycholic acid, and have 3 monthly or 6 monthly blood test and a repeat Fibro Scan at 12 months. And then we can assess your urso response. If your alk phos has not improved, and if your Fibro Scan is still very high, you will qualify for second-line therapy with either obeticholic acid or something else. Did that person give bilirubin reading? Do they have normal bilirubin?
It's not part of the question, so we'll have a look at that. So
yeah, what's just the comment that Sarah has made, she's got a bilirubin of 40. Okay, Sarah, you made a comment about you haven't heard from your gastro, so I'm assuming you're not being seen at a liver unit. I would quite like to have a wee chat with you if you go to Linda at the office and get my phone number anytime, evenings or weekends. Let's have a wee chat about this, and we can get this moved forward a wee bit quicker than what it seems to be happening at the moment. So please do that.
Perfect.
Yeah.
So so this is a convoluted comment. So we have been putting together a series of videos for PBC Day, which we're incredibly excited about. And we have a certain expert on itch who we're looking forward to seeing their video. So we'll get together and record that very shortly. But one of the topics of one of the videos is the history of PBC.
Yeah.
So for those of you that are newly diagnosed, again, just a little reassurance in terms of, in the olden days, the standard of care, i.e. the best treatment there was for PBC, was liver transplant. And then in the 90s, there came this thing that nobody had really heard of, which was ursodeoxycholic acid, which was a game changer. Nowadays, in terms of obeticholic acid, which is now licensed as a second-line therapy. So there's already our plan A or plan B. We have off-license therapies, that Vinod could go into much, much greater detail than I could. We have a plan C. We have clinical trials on the go for second-generation fibrates. So there's our plans D and E. And so we have all these options now. So if you are new to PBC and you're coming in and you're thinking, oh my goodness gracious me, where could we go from here? Actually, there is a really nice laid out series of plans to help mitigate the disease over many, many, many years. Yeah. So I just wanted to give that background.
I can add to that by saying, and I'm here as evidence, and I'm pretty normal. Normal's not a good word to describe me. Pretty average. I mean, I'm now 65. I know what you're thinking, Vinod. I look more like 45, but I'm now 65. And I was diagnosed at the age of 37. I had the symptoms as a teenager. So, and there was nothing when I was diagnosed. So, Sarah, we've got it all there for you. And anybody else who's listening, just pop me a wee phone call and we can get moving.
Okay, perfect. So as a man knows one or two things about itch, no pressure.
Yeah.
So there was recently an Ask the Expert session with the American Liver Foundation.
Yeah.
So that went on. Now, the doctor there, he wasn't explicit. And so there's a question that's come in that's maybe looking for a little more clarification. But he alluded to the fact that itch can sometimes mean a more aggressive form of PBC. And I think this has put a bit of a fear wave over the community. So can you maybe clarify that, and again in lay terms, what it actually means in real terms?
I am not convinced based on the evidence that severe pruritus or severe itch is a direct marker of aggressive disease. There are few studies here and there to say that, but on the large scale studies have not proven that. So I would tell my patients that just because you're symptomatic with itch, it does not translate into you having an aggressive disease. They are slightly two different sides of the same coin, I would say. Because your itch, first of all, we don't know what causes itch. That's a separate discussion altogether. What we know is if you are a ursa non-responder, by that I mean your alkaline phosphate is still very high, there is evidence that you're more likely to be itchy. Okay, so obviously we know that people who are ursa non-responders are more likely to have aggressive disease. So you can say that ursa non-response equals aggressive disease, and if they are symptomatic, there you go. Okay, so itch is a marker of, or itch is associated with ursa non-response, therefore more aggressive disease. Having said that, I have seen patients with really, really bad itch, even with normal levels of alkaline phosphatase or slightly lower alkaline phosphatase than the below the threshold of non-response. So it is not a direct linear association between itch and alkaline phosphatase or itch and aggressive disease. Okay, so I would like to reassure this person that it does not always mean that more symptoms equals more aggressive disease. Is that all right?
That's very all right. Maybe we could get a chat in the future, because Robert, we have been carrying out lots and lots of surveys, but I was telling Dave Jones about this. We're getting lots and lots of people telling us they've managed to stop the itch by changes of diet, changes of really quite major things. And sugar and chocolate and various things have come into this. So maybe in the future, and I know it is your thing, we could maybe have a chat about what's being said to us, and we can give you some of the results of these questionnaires, but not to be ignored at this point.
No, absolutely. That's right and fair. So thank you.
Cover some of that in the video that I'm supposed to do for you guys.
Supposed to do.
I was supposed to do it by 15th of July. But,
bad boy. You're a busy man, we know.
So on the subject of itch, so Vinod was party to. So if you haven't already done it and you have the app, please take part in the itch survey. This is really, really important. Now, Vinod, I bang this drum all the time, so the people who come in regularly are probably bored of hearing it in my voice. Now that you have seen some of the results of the survey, you were involved in writing the abstract that has gone to AASLD. Could you maybe say a little about itch research that's going on at the minute? So, for example, we know that Glisson is about to reopen. Obviously, we know that we've been working in partnership with Essient. So can you say a little about the survey, itch research, and why we do what we do?
Yeah, it's amazing, isn't it? The power of patient-delivered information. What that app has shown is patient-reported information is so powerful, far more powerful than any clinical trial or anything, because this is a real world data. Okay, this is you guys telling us your quality of life, your symptoms. So the two things that came out of that PBC itch survey via the Foundation's app, how common it is. First of all, it's really, really common, much more commoner than clinicians like me would like to think, right? So up to 70 to 75% of PBC patients experience the symptom at some stage in their life. Okay, and that is the first message. So it's a very, very common condition. The second thing that came out, which also doesn't surprise me because I've done a study like that before, is how undertreated or how poorly treated this symptom is. Okay, so people, I don't know the reasons for that, whether they don't go to their GP or they don't report it to their clinicians or they don't ask for the treatment. I don't know. So, but it is very, very poorly treated in the country. It's common and it's undertreated. So if you have the itch symptom, please, please, please speak to your gastroenterologist, speak to your liver specialist and ask, because there's a very, very standardized, protocolized treatment available, and every patient with PBC should be offered treatment according to that. No patient with PBC should suffer the symptom. Okay, in majority of the patients, it is treatable with simple medications. So please, please report it, ask for treatment, and yeah, that's what came out of that itch survey, didn't it, Robert?
But we want you to continue to answer the questions about the itch, because we've got more questions up there about food and ingestion and all the rest of it. If you don't itch, please reply to, please fill in the questionnaire. And if your itch has been treated successfully, we want to hear from you as well. So we want everybody's comments. And, you know, somebody's personalised it. Jill in Nottingham, she really suffers with her itch. She's saying, please do it for me. So let's just all do it for Jill. Please, please, please keep those numbers rising and give the experts information.
Absolutely. And the other power of that app and survey is, please, because there is no other way to get this information in the current age, is what is the actual response to these medications? Nobody is going to do another trial on cholestyramine. Nobody is going to look into rifampicin or naltrexone or fibrates. What is the impact of these drugs on itch? We don't know, because all those studies were done 20, 30 years ago. No companies involved in these drugs. Nobody's interested. So there are a number of unanswered questions about these medications. But with your help, with the itch survey, we can ask what medications you were given, how many were treated with this medication, how many responded, you know, the efficacy of the drug. For example, if you say to me that I took Questron or cholestyramine and it did nothing to my itch, okay, it did not help. So if 200 people answer like that, and only 20 people say it cured their itch, there you go. We have a real world data saying that the efficacy of cholestyramine is only 10%. So we need that kind of percentage figures to understand the burden of this symptom, to understand how the unmet need, you know, that's the phrase we use all the time, don't we, Robert? Unmet need in PBC. So we need that type of information about itch medications. I would really like to see that in large numbers through this Foundation's survey. So please do that.
Would you add that into the piece of film that you're going to do for us, Vinod? I think it's important when it comes from doctors. It's important.
Yes, absolutely. Yeah.
Thank you.
I'm going to let you breathe for a second, because the passion in there was fantastic, and this is what we love. And it's, you know, we are so lucky in terms of the partners of the Foundation. You know,
Absolutely.
Ask Dave Jones about fatigue, and you're going to get the arms and the animation and the passion. Ask Vinod about the itch, you're going to get the arms, the animation, the passion. This is really, really important, because it's great for the patient community to see how much the clinicians care, how much they're invested, and how much they want to help us find an answer together. So, Vinod, again, great answer. So thank you. I'm going to bring you back to lay terms now.
Yeah.
How can we describe brain fog in lay terms?
Well,
you're getting all the easy ones today. That's another cracking question.
It's a very variable symptom, isn't it? And it's one of those symptoms that we know very little about, and it's an unfortunate thing because a lot of people do suffer with it, whether it affects their cognition, their memory, their ability to do day-to-day things. As Collette said earlier, simple things like, did I take my ursa yesterday or not? You become forgetful. Okay. It's not as profound as symptoms of dementia. So I don't think it is as bad as that. But it is very clear that the cognitive impairment of PBC is a significant disability for significant severity of minority of patients. So how do you describe it? Well, it's a subjective symptom. Patients describe it in different ways. Patients' family members who come with them, they also describe it in different ways. But majority of the patients describe it as, temporary inability to comprehend, temporary inability to remember things. They're doing crosswords, and even simple crosswords they can't answer. Sometimes they have to check whether the gas is on, whether they have locked the door or not. Simple things like that, and that is how I've come across it in patients that who describe it. But the fact is that there is no treatment for this yet. It is a well-recognized symptom, what we call as extrahepatic manifestation of PBC. It is probably part of cholestasis, but I think Dave Jones is doing more research on that, and hopefully we'll have treatments as well.
He absolutely is. Yes, we're all watching that space. We're all looking to Dave at the moment. But yeah, absolutely. I mean, my boiled egg, my history with boiled eggs on my ceiling, I put them on. Yes, I will remember. Of course I will. So it's funny little things. And it doesn't seem to last for any length of time. It's not as if once you can't manage a word in a crossword and that's it, the paper's gone for the day. It comes and goes. And I think it is dependent on other things in your life as well. Your level of fatigue, and if you're in the menopause, and all lots of things as well. And somebody's asking about brain fog different. Yes, that is different to HE. Yeah.
So actually, that same question came up in Facebook as well. So I'm hoping Jen's in the room, because I think this is one of our mythbusters that we need to address. So the question for you, Vinod, is brain fog different to HE, which full name hepatic encephalopathy?
Yes, definitely. Brain fog is different to hepatic encephalopathy. Hepatic encephalopathy is a specific phrase or term given for patients with liver cirrhosis. You have to have cirrhosis of liver to develop hepatic encephalopathy, and that is related to the buildup of ammonia, one of the chemicals that liver is able to detoxify very normal in normal people. But in cirrhotic patients, liver is unable to detoxify ammonia, and ammonia builds up in your system, crosses your blood-brain barrier, and that causes a degree of disorientation, confusion, memory impairment, sometimes coma. So there's a spectrum of that. So that is hepatic encephalopathy. The brain fog in PBC is nothing to do with ammonia, is nothing to do with whether you have cirrhosis or not. It can happen to anybody with PBC. So they are two different things completely.
Perfect. Okay, thank you. So I'm very much aware of time, so I know you need to fly off soon. So magnesium for pain, is it okay to take with PBC?
For what? For pain?
So I think it's for pain and or sleep.
Cramp. People talking about night cramps as well.
Yeah, that's coming up as well. So, is magnesium?
It should be okay. I'm not aware of any direct toxicity of magnesium to liver cells or cholangiocytes, but obviously in moderation, anything is good. In excess, even good things become bad.
Yeah. Okay.
So you can.
Okay, thank you. We've had a few questions about cramps, so pains in the legs. So can you talk a little about that? Is that associated with PBC?
Leg cramps are not, they're not a recognized direct associated symptoms of PBC, but I guess they are such a common symptom, especially as one gets older. You get these night cramps or leg twitchings or muscle cramps, especially during the end of the day or when you're in bed. So people report that. It's common. I have seen a lot of PBC patients reporting it, especially elderly people. And the usual treatment for that, I give them quinine. Quinine tablets are available, and those
Okay.
are first line treatment for leg cramps is quinine. And if that helps in majority of the patients, drinking simple tonic water may help as well.
I was going to say without the gin, yeah.
Without the gin. It contains similar amount or less amount than the actual tablet, but that might help. But if it is quite severe and doesn't respond to quinine, I think there are other medications available as well. But I won't hesitate referring the patients to elderly care specialty, because they are experts in managing leg cramps.
Excellent. Yeah.
And there are other drugs available.
Okay, perfect. Thank you. Do you have time for a couple more, Vinod?
Yes, absolutely. Yeah. Absolutely.
All right, thank you. So we've got a question about Fibro Scan.
Yeah.
So to try and keep this as brief as possible, there are issues that Fibro Scan in terms of its accuracy.
Yeah.
And the fact it's not diagnostic per se. So can you maybe say a little about those two aspects, please?
Fibro Scan is very, very well established in PBC monitoring now. Okay, so it is a part of standard assessment of liver fibrosis, liver scarring. It's not true that it's not diagnostic.
Okay.
It is not diagnostic of PBC. Okay, I see what you mean. Fibro Scan does not help me in diagnosing PBC, because PBC is diagnosed based on your antibody and your blood test. Fibro Scan is used to assess and diagnose staging of the disease, which means how much scarring do you have in your liver. Historically, we need a liver biopsy for that, which is sticking a needle into the liver, which we don't do anymore. We do less and less of that, thankfully. Fibro Scan it gives you a global picture of the entire liver. Okay, it's just like an ultrasound scan. For those who don't know, you go to a clinic and a nurse lies you down on the couch. They put a probe on your rib cage, and it sends the vibrations into your liver, and it sends back to the probe, which is connected to a computer, and within 3 to 5 minutes we get a number. Okay, that number that is generated by the computer is the measure of liver stiffness. It's called median liver stiffness. Okay, or liver stiffness measurement, LSM. And the higher the number, bad it is. Okay, so if your score is below 10, you do not have advanced fibrosis or advanced scarring. But somebody said earlier the Fibro Scan number was 19. Somebody's could be 25, 30, 35. So as it goes over and over that, it does raise the suspicion of advanced scarring. So it's a very important tool. We use it very regularly. We have a system to do it every 2 years for majority of the patients with PBC. So it gives me a objective marker of disease progression over the years. Not everybody needs it every 2 years. For patients with high risk disease, we do it every 2 years.
There is something called the ELF test as well. I know one or two hospitals, they don't do Fibro Scan, but they do this very expensive, I'm told, £100 a blood test, and the ELF test is good to understand.
That's a surrogate marker of fibrosis. It's probably not as good as Fibro Scan. I don't think it is validated in PBC, but in general for liver fibrosis, ELF test is good. Okay. ELF is usually used for fatty liver disease, non-alcohol fatty liver disease, and all that. I have not used ELF test in PBC. I don't use it, but we have Fibro Scan, of course, and we do it.
Excellent. That's a good point you've made. Thank you, Vinod.
All right, thank you. Last question of any seriousness.
Yeah.
We've got somebody who was assessed for URSA response, and it was decided last July that they have not responded to URSA. There has been a conversation about obeticholic acid, but they've not started it yet.
Okay.
And they're concerned that they've not started it yet. So again, what can we help with in terms of what's the next question? What can they do to help themselves on their care pathway?
Okay. So obviously, during the COVID times, everything is delayed. Every service is affected. But in general, once a decision has been made that patient is eligible for obeticholic acid, in general, the medication should be started in the 6 weeks or 8 weeks. That is what we do in Leeds.
Yeah.
There is a process for that. The MDT approves that this patient qualifies it. The pharmacist has to complete a blue tech form that has to be completed and sent across, and then the medication company, the home care company, delivers it to the patient. In general, there should not be more than 6 weeks delay. So I don't know this person, I don't know how much delay they are experiencing. If it is still within 6 weeks, don't worry too much. If it is taking longer than that, you should speak to the clinician or nurse if you are in touch with them.
Yeah, they were saying last July, whoever that person is, happy if you want to ring me. Do know that's a year. That's enough now. That is a year. So I would suggest that you email your consultant and put urgency on it, and you can refer to what you've heard here today.
A year is far too much. It's too much delay. That should not be the case.
Perfect. All right.
You may have been lost in the system, so please remind them.
Absolutely. Don't be afraid to remind. Everybody makes mistakes, so it's fine. It's okay.
All right, brilliant. Thank you. So, to be respectful of your time, Vinod, I'll thank everyone for your questions. We've got an apology to make. It seems somebody's been shot in a time lag, and they seem to have watched last week's because they say, "Goodness, this man is brilliant. He's answered so much in a short time, easy to understand. Thank you so much, Doctor and PBC Foundation." So they must have been last week.
Absolutely spot on. Wonderful.
So, Vinod, you and I have shared a stage on many occasions. It's always a pleasure to work with you.
No, likewise. It's always a pleasure.
Great friend of the foundation. Great friend. I know, Sarah, you had another question about diet and what have you. We've been chatting that on the phone, and you can come in next week and the week after. Vinod, thank you so much for your time. I know how busy you are down in Leeds. We get to hear on the grapevine who's very, very busy and who's not so busy. I'm not saying anything about David Jones. I never said the words. No, I'm teasing. So, and buy his book, by the way, everybody. David Jones, buy his book. Vinod, thank you so much. I hope it's not too long until we meet again. But if we can help you or anybody in your neck of the woods, then please don't hesitate to ask. Robert, we're on countdown to how many? I don't know how many 2 o'clocks we've got left with you. It's very sad.
So I think we will have a replacement for next week. So this could well be my last one, actually. So yeah.
Well, I do not have waterproof mascara, so I'm doing no tears if I can help it. I get very weepy. But if it is your last one, I hope it's not Robert, because I hope you'll keep coming back. But we've got a fantastic replacement. Everybody, his details will be going up on our website very, very, very soon. Vinod, you'll meet him. Vinod, it's been an absolute delight and a pleasure. Robert, what can I say? If it is your last one, I will go away and cry now. I'll get quite emotional. Thank you. Right, out of my house, please. Out. Thanks, everybody. And Sarah, phone me.
All right, take care. Thanks again.